Thank you very much. My pleasure to share with you this afternoon some of my work on COVID-19 and some more general thoughts on COVID-19 as well. I came from the United Kingdom. I studied a degree called Morse in my undergraduate. It's a degree combining mathematics, operational research, statistics, and epidemiology. And I suppose when I decided to take that degree, I wasn't quite sure what I wanted to do, but I gravitated towards statistics, the S in Morse, and I continued at Warwick University to do a PhD. And then I came to Hong Kong soon after I finished my PhD. And since I came to Hong Kong, I've been working in the field of infectious disease epidemiology. That's the study of infections, who gets infected, when they get infected, where and how and why. And there's a lot of interesting questions we can study in this field. I analyze data that I collect myself. I'll show you some of that later. I also analyze data collected by other people. And an example of that is on the right-hand side of this slide. This is a piece of work I did very early in 2020 in collaboration with scientists in Beijing at the Chinese Centers for Disease Control and Prevention. We looked at some of the earliest COVID cases. And on my own computer, late at night, I generated panel A. That's the incubation period. That's the average time from when someone gets infected until when their symptoms appear, typically within a week, rarely as long as 2 weeks, 14 days, and very rarely beyond 14 days. And that estimate still has relevance even now, 2 years later. So I'm very proud that I was able to do that myself, because often I have a team of people getting to do the most exciting things, and I'm not doing such exciting things sometimes. I came to Hong Kong in 2004. That's me looking very thin and youthful. I was hired by Professor Gabriel Leung, who is the dean, of course, at the Faculty of Medicine at Hong Kong U now. He hired me all those years ago to join a new team in infectious disease epidemiology. At that time, there were just a handful of us, but over the following years until now, our team's grown and grown and grown. And now we have 50 people, actually I think more than 50 people now working in this field. So it's really a very large research group. And the concept of our research group was that we would study whatever interesting questions we can think of in infectious diseases. And when there's an emergency, like with COVID, we'll be ready to handle whatever we need to do for COVID, and we'll stop doing the other projects that we were doing. And that's worked really well, because in Hong Kong, I think we have excellent scientific research capacity now for COVID-19. I'm going to talk a little bit about COVID epidemiology, vaccines, and I'll get to zero COVID by the end in the next maybe 15 minutes. The chief executive of Hong Kong emphasized from the very beginning of this pandemic that the decisions of the government are scientifically based. You can read the quotation on the right-hand side of the slide explaining that the science is really, really essential to deciding what policies to implement. And there's a number of components, of course. In order to have evidence-based decisions, the first thing that you need is the information, the scientific data, and then you need the right kind of analysis in order that you can make the right interpretation of the information that you have. One of the earliest observations that we made, and of course communicated to the Hong Kong government, is the severity of COVID. So prior to the pandemic in 2019, I worked with the World Health Organization looking at the kind of strategies that could be used to do what's called flattening the curve. And the concept we had was, maybe there's a new infection like COVID, something else, and if we don't do anything, we'll have a very large epidemic like the one shown in green here. And what we'd like to do is to flatten it out so that you can see the consequence here. We'll delay the time of the peak, and that means we buy time to react. We'll reduce the height of the peak downwards. So at the very worst point in the epidemic, there's less people in hospital, less people in intensive care, and that means we can handle everybody a little bit better, that the doctors and nurses can look after people better, and then we spread the cases out. So that's what we mean by flattening the curve. But with COVID-19, we realized a problem very quickly. Based on our own research, our own analysis of the severity of infections, we realized that even if we flatten the curve really well, even if we do a really good job and the blue curve is a long way to the right and is much flatter than the green curve, even if we have very effective interventions, we'll still have a very major problem with COVID, that the infections will substantially overwhelm the healthcare system capacity. There'll be far too many people needing to go to hospital, far too many people needing intensive care all at the same time. And so the conclusion was, we can't have any blue curve. And that's something that's really, really difficult to achieve, because if we don't do anything, we're going to have a big green curve. And what we need to do is somehow to stop any curve at all, or have an absolutely minimal curve. And that's, I would say, almost never been achieved before for an infection with the characteristics of COVID-19. But we have managed that in Hong Kong, and a few other places have done very well as well, of course, including the mainland. We recognize very early that COVID is more of a threat than influenza, and this figure just illustrates the scale of the difference. Influenza epidemics are shown at the bottom of this slide in yellow, and the 2017 to 18 influenza season was a big flu season in the United States. It was front page news. Hospitals were full of flu patients, and that was considered something that maybe the government could have a response to try and make things better. And then you look on the right hand side, the scale of COVID-19 so far in the United States. 1 in every 500 people has died from COVID-19, which is a remarkable death toll. And thankfully, we haven't had anything like that in Hong Kong. So one of the first contributions we made locally in Hong Kong was to estimate the reproductive number. In infectious disease epidemiology, in my field, this is a really important quantity. It tells us how quickly an infection will spread through a population. And so an infection with a reproductive number of 2 means that one person spreads on average to 2 more, they spread to 2 more. So you have 4 infections in the 3rd generation, 8 in the 4th generation, and so on. And it keeps getting more and more and more. And if that keeps happening without stopping it, very soon there's a very large number of infections. So if we can estimate what the reproductive number is, we can have an idea of how much effort we need to make to stop it. And so my research group in Hong Kong U very quickly came up with the methodology to do that. And we couldn't use the methods that other people have used in other parts of the world, because in Hong Kong, we have quite a number of what are called imported cases. That means people that were infected elsewhere in the world and then travel to Hong Kong, and we detect them here. If we use the standard method for reproductive numbers, we end up counting those people as if they were infected in Hong Kong. And that's not the case. They were infected somewhere else. So we actually modified the method so that we could have a better estimate for RT, and we posted it on our dashboard. It's stopped right now because we haven't had any COVID cases for quite some time. We haven't had an outbreak in the community for quite some time, but we were estimating that and posting it every day so we could keep track of things. And here's the figure of how that RT went up and down over time. You can see each time we got the second wave, third wave, fourth wave under control, that corresponded to periods of time when the reproductive number came down below the critical threshold of 1. There's a slightly worrying sign in the fourth wave that we had trouble getting the reproductive number below 1. And if you remember, the fourth wave did drag on for quite some time. And that makes me a little bit worried about what would happen if or when we have a fifth wave and we try the same control measures again, because now with the new variants of COVID being more transmissible, with maybe some level of fatigue in the population, it may not be so easy to get transmission under control again. How do we manage to get infections under control? 2 basic types of methods. One are the targeted measures. So that means when we find cases, we isolate them at the moment in hospital, and then we also trace their contacts and send them to quarantine, right now often in Penny's Bay. And so that's really, really, really disruptive to the individuals who are sent to isolation or quarantine. But the idea is it's for the greater community good, because the alternative types of measures are the community-wide measures that apply to everybody. And so they disrupt everybody's lives. And I think in Hong Kong, we have a good balance actually with the targeted measures that are disruptive on some individuals, but because we have those, which they don't have in most other parts of the world, we don't need so much of the community-wide measures, and we've been able to avoid the strict lockdowns that many other places have seen. So, for example, the mask use in Hong Kong has been excellent since the very beginning. Everybody's been wearing masks very well, and I think that that's made a big difference. But at the same time, even with the mask use, even with the targeted measures, we've still had outbreaks of COVID in the community, and so we've needed these intermittent use of additional community-wide measures that are disruptive in responses to those surge in case numbers. And in each of those epidemics, the second wave, third wave, fourth wave shown on this slide, those measures have been successful in bringing the epidemic under control. So what's next? We have vaccines available, and vaccines have two modes of action. So some vaccines can reduce the chance of an infection occurring, and that's primarily through what are called antibodies. Those are proteins in the blood that bind to the virus and stop it from being able to get into your cells and use your cells as factories to reproduce copies of the virus. And then those are what end up making you sick, and then also end up spreading to other people and perpetuating the infection in the community. So some vaccines are really good at generating a lot of antibodies and help to stop people from getting infected. And then some vaccines maybe don't necessarily stop you from getting infected, but they do reduce the chance that the disease is really, really severe. And the protection against infection is thought to be generally with antibodies, and the protection against severe disease is mainly conferred by what are called T cells. That's a type of white blood cell. And the vaccines that we have in Hong Kong are able to generate very good T cell responses. In terms of antibodies, one of the projects that I've been doing, and this is where I collect my own data, is following up people in Hong Kong who decide to get vaccinated and then measuring their antibody levels. And on the left are the antibody levels in people who receive Sinovac, and on the right are antibody levels in people who receive the BioNTech vaccine. And on this axis, anything above 30 is okay, and anything above, I would say, 50 or 60 is pretty good. And so after the second dose, there's a lot of people who do well on Sinovac, but almost everybody gets very, very high levels of antibodies after receipt of the BioNTech vaccine. And so we expect that the BioNTech vaccine to be maybe better at preventing infection. But both vaccines, as I mentioned, can have this protection of severe disease. And then we continue following up the people in our studies in the community to see what happens over time. And we see the people who receive Sinovac, the antibodies tend to go down and down and down over time. And by about 6 months, they're at a pretty low level, by about 6 months after the second dose, whereas the people who receive BioNTech still have pretty high levels of antibodies after 6 months. So that's the justification locally. If some of you have been wondering, why do people who have the Sinovac vaccine need a third dose, but the people who get BioNTech don't? It's because of this kind of result where the people who got BioNTech first actually are still having pretty high antibody levels. They can get a third dose, but it's not urgent. Whereas for the people who receive Sinovac, most of the protection against infection has likely been lost, according to the data shown here, within 6 months after the second dose of vaccination. So thinking about what's happening now in Hong Kong and what could happen in the future, there are two basic strategies which have been discussed in the news and discussed by the government. The first one, which we're doing, is to maintain zero COVID. And then the second one, which you may have seen Singapore have adopted, Australia, New Zealand have adopted, which is the gradual relaxation of public health measures, not an immediate drop of everything, but a gradual relaxation once vaccine coverage is at a high level, ultimately aiming to get back to what was considered normal life before the COVID pandemic. And we can continue with the zero COVID approach in Hong Kong for quite some time. And in mainland China, I think they can continue for quite some time. Ultimately, at some point in the future, I think we'll have to switch from number one to number two, but maybe not for a while. The key parts of zero COVID, there's really two components. The first one is if there's an outbreak, we need to get case numbers to zero. And we've achieved that after the second wave, the third wave, and the fourth wave. Unfortunately, we haven't had any outbreaks in the last 6 months. We've done very well. Sooner or later, we will have another outbreak, and we'll need this phase again of very stringent community measures in order to get back to zero. If you've seen the disruption in the mainland in the last 1 or 2 months because of their outbreaks, I think that's the kind of thing that we may anticipate happening in Hong Kong in terms of very stringent measures and a lot of laboratory testing in order to control an outbreak. And then the second part is the staying at zero. And the key part of that is the strict on-arrival quarantines and the surveillance, regular testing of high-risk staff. But actually, we can relax the domestic measures. So I know all of us are still wearing a mask all the time in Hong Kong, but actually for the last 6 months, we haven't had any real community outbreaks. We haven't had a fifth wave. And until there's community transmission again, the government could consider relaxing the masking policy, because domestically we don't have any COVID cases. I think the New Zealand experience with the zero COVID approach is really informative. They've documented their experience of keeping COVID out of their community, and a number of times COVID was able to get into their community. In Hong Kong, we have the same. We've had a number of times when COVID has got into our community. And when they look at how introductions occurred with their strict 14-day hotel quarantine in New Zealand, this is over the period of almost a year. There were 13 different introductions of the virus where it managed to slip into the country. Not a single one was because an infection became apparent more than 14 days after arrival. There were no really long incubation periods, but what did happen was cases in aircrew, cases in container ship staff, or people working at the container terminal, or people who got exemptions from quarantine. And those are the things that we also recognize are things to be very careful about in Hong Kong, that although we have very strict hotel quarantine, we still do have risks of the virus getting into the community. If or when we eventually decide to return to normal, we have to anticipate what would be called an exit wave. And that's what Singapore are experiencing right now. Also in Europe, many different parts of Europe are experiencing rising case numbers. Fortunately, the levels of hospitalization are not so high as they have been earlier in the pandemic. But in Singapore, I know they're very concerned about what's going to happen with rising case numbers, what's going to happen when there are rising numbers of hospitalizations with COVID, when they're no longer pursuing a target of zero cases. I was thinking to myself, what are the advantages or disadvantages of the different strategies for the zero COVID approach that we're following in Hong Kong and also in mainland China? There's a number of advantages. We can minimize the health impact of COVID-19, and we can have the chance of a quarantine-free travel bubble with the mainland. There's a lot of promising signs about that recently, and there's major economic advantages for Hong Kong to do that. At the same time, we also have the disadvantages of the public health measures, the travel limitations and restrictions and so on. Whereas if we were to switch over at some point sooner or later to maybe the Singaporean model, the advantage would be we can relax those public health measures. But the disadvantage would, of course, be that we'll have health impact of COVID in our community, and we wouldn't be able to have that travel bubble with the mainland until at some point in the future they also decide to return to normal. So I can see why the government's electing to follow the zero COVID approach. There's a lot of advantages, and I suppose they outweigh the disadvantages. So I'm coming to the end now. In terms of the evidence, from my opinion, the needs to support policy, I think is really valuable in Hong Kong that we have such a lot of capacity for laboratory testing, because that means with COVID, we can really have a very good picture of what's going on in Hong Kong. And a very recent example of that is the detection of the Omicron variant in Hong Kong, one of the few places in the world that has detected it so far. And that's because we not only test the people arriving into Hong Kong, but we also do the genetic sequencing of those positives, so we can see what's going on in the rest of the world. And I think that given that we've detected the Omicron variant in Hong Kong, with probably just a small number of travelers coming in to Hong Kong from Southern Africa in the past month, and we've detected the Omicron variant in one of them, I think is highly likely that the same variant has traveled to many other parts of the world by now. They just haven't recognized it, maybe because they haven't been doing as much surveillance as we have in Hong Kong. And then the second issue that I think is really critical is the technical capacity we have here in Hong Kong. In SARS in 2003, there were very few experts in infectious disease epidemiology. And now there's a lot of experts in infectious disease epidemiology. You turn on the news and every day there's an expert talking about the current COVID situation and what's been happening and what we need to do. And I think this improvement in knowledge, improvement in technical capacity has been really valuable for Hong Kong. It means that we can have evidence-based policies, we have domestic evidence, and we have the right kind of decisions made based on scientific evidence. And then the last point I think that's also been important in the past 2 years is that policies can be updated and changed. They're not set in stone once they're announced. So we've seen a number of times policies introduced and then fine-tuned once we have new information available. And I think that's going to be a feature going forwards as well, that once new policies are announced, we'll see more and more information becoming available on how well they're working, and then maybe fine-tuning of those policies in light of that new information. And that's a really important feature of the policy making in Hong Kong. So my final slide, COVID-19 is still a major threat to us in Hong Kong. The vaccine coverage here is not really high enough to allow us to return to normal. And there's major advantages anyway of the zero COVID approach with or without high vaccine coverage. And so I think for now, we will continue with the zero COVID approach because of all of those advantages. But sooner or later, we will have to think about what's the exit strategy. And that's not something that can be done in a very short period of time. Singapore had taken, I think, 6 months to plan out their exit strategy. And then actually going through the exit process will take many months as well. So we haven't started that process yet in Hong Kong. That means we have quite a long way still to go in this pandemic. And with that, I will finish, and I'm ready for some Q&A if you put them in the box.